Okay. So, Dr. Curran, from what I could gather, I think we've had a total of 6 members, if I'm correct. So I'm not, I guess we can continue on.
I think so, and if others may join, we can count them as they join.
Sounds great.
And I think we turn this over to Commissioner Toomey.
We have to approve the minutes from the last meeting, though?
I guess we do that for you, do that, right?
Correct. You've all received the minutes from the last meeting. There's no questions. Just send it back to Dr. Curran so we could go ahead and have those minutes adopted. Motion, please. I think that folks may be having audio problems, so I'll go ahead and motion. I guess Dr. Curran, you'll second. Okay. And we'll since we'll stand approved then.
Dr.
Curran, back to you. You're on mute.
Now we move on to Commissioner Toomey.
Yes, thank you so much. It's so really good to be on this call with you. Many of you, though, I've been interacting with on a regular basis, particularly you, Chairman Curran, throughout the pandemic, both for your help and our partnerships that I'll talk a little bit more about. But also Dr. Cheek, who was my personal advisor on schools and how to open them up safely. General Carden, who was one of our partners throughout the pandemic, both for testing and vaccinations. And I don't know if Dr. Cole is on. He was one of our first vaccinators and really did a tremendous job in promoting vaccination in Oconee County. I do want to also introduce some new staff that you haven't seen since our last meeting. They aren't here in the room with me. We were trying to minimize the number of staff in the room, and I don't know if you can see me, but we're all masked up because we're tightly packed in this room. But Melanie Simon, is our new general counsel, I'm delighted to introduce her. Many of you may know of her already. Melanie was in the Department of Community Health and worked closely with us on long-term care facility regulation and the epidemiologic follow-up. And so if that name is familiar to you, it should be, because she has been a long-standing partner and ally with us in public health, and now she's our general counsel, and we're delighted to have her on board. I also wanted to announce that we have finally a permanent Chief Medical Officer. That was a position that was recently filled by the General Assembly or was funded by the General Assembly, and we were able to recruit just a really wonderful public health physician, Dr. Alex Millman. He is serving as the overseer of all of our medical programs, including immunizations and HIV, and has quite a plate to deal with right now, and we've really been pleased to have his support and help. So I know that you'll look forward to working with him, and as I have, and we'll be meeting him soon, and feel free to reach out to him. We have a really very good agenda today to kind of bring you up to date on what we've been doing and since we last had a chance to talk. But I just wanted to say a few words that actually mirror very much what Dr. Curran said, but with a little different twist. Like so many of you this weekend, I imagine, who were on Saturday thinking about the events of 9/11 and where you were at the time you first heard the news that the planes had hit the World Trade Center and our world, changed forever. Believe it or not, I started thinking, well, I was in this very room I'm in right now 20 years ago. And after talking to the state and territorial health officials over the weekend, I realized that I am the only current state health official who also was the state health official during 9/11. And what a privilege in some ways it is to have been at both these extraordinarily difficult events. What an amazing perspective that has given me on what public health has and has not been able to accomplish over the last 20 years. Certainly immediately following 9/11, public health moved to become a Homeland Security agency, and we moved to into the incident command system. We became part of the response system that we hadn't been as fully part of before. We expanded our capacities, and many of the bioterror agents, both in our laboratory and with our epidemiology team. And at the time, we received what seemed to be massive increases in public health investments, much of it going to equipment, communication assets, expanded laboratory capacity. But as my ASTO colleagues said to me over the weekend, but what has followed in those 20 years has been what we have seen as a boom or bust cycle of budget increases during emergencies, and then those increases get reduced or cut back, and then we're not left with a sustained investment in the public health infrastructure that we need. Mike Frazier, who with whom I was communicating, described what he saw looking nationwide, just as we saw here, that despite the tireless efforts of countless public health staff, there was a disconnect between local, state, and federal data systems, and that was certainly the case here on so many levels, both not only with testing, but also with our vaccination system. And our inadequate medical supply chain that had been left, the stockpile was not up to date, and we didn't have the surge capacity to meet the national demand for contact tracing for a disease that would have millions of cases, not just 18, like our Legionella outbreak that we talked about so many times, or the measles outbreak. What I want to leave you with is this thought that I've been thinking about a lot over the weekend and through the last several days. This pandemic has offered us a once-in-a-century chance to transform our public health system into an integrated health system with a state-of-the-art data reporting, staff training and development, collaborations for staff growth with universities and the business community, and no longer siloed health systems. Medical care providers here working independently from public health, and hospitals working independently from public health or even providers. The time to be building these systems and these partnerships is not in the middle of a pandemic, as we are finding ourselves doing, but that should be our standard of public health care. And we can build it and sustain it now. With that in mind, we hope to use the categorical and targeted grant funds from CDC to begin to build that ideal system, creating a public health data system of the future that includes updated data collection and reporting linkages to private sector providers, as well as a uniform electronic medical record in public health for the first time. We've received support as well from the Georgia legislature, the General Assembly, to modernize our vaccine management system, as well as create what I've been calling the surveillance system of the future, which I hope will ultimately allow us not only to collect and analyze infectious diseases, but other health conditions from all providers and entities to build that public health infrastructure we need now, as well as in the future. I sent you an email last night. I hope you looked at it. That really has a summary of our federal grants that was put together by our team. And you can see that what we are doing with the federal grants is building on the assets we've received from the General Assembly to create a system that can respond proactively to public health threats, as well as better manage chronic diseases, HIV, and ultimately, we hope, address the social determinants of health that have led to the inequities we have seen throughout this pandemic. An important part of this work will be to continue to be developing staff training and support. in order to respond adequately to the massive needs for contact tracing during this pandemic, we not only surged internally, but also collaborated with the CDC Foundation, who helped us enormously to place contact tracers and epidemiologists statewide. But I have to take this opportunity to, with great gratitude, thank Dr. Curran for his vision, because he and under the leadership of Dr. Allison Chamberlain were able to work with us and the Woodruff Foundation to create the Fellows program that really created a mini EIS program, in a sense, in Georgia to train public health professionals and train epidemiologists in the field, simultaneously providing training, but also giving us additional capacity out in the districts. Meeting these critical staffing needs now, and what I truly believe will be building the public health leadership of the future as we do so. And that really was an opportunity that Dr. Curran was able to make possible. And for that, we truly thank you and are forever grateful. And I think we'll have an impact not on Georgia, not only through this pandemic, but throughout the future. And I hope will be a model for other state programs as well. Like Jim, I want to close with an acknowledgement of the incredible gratitude. I'm going to start to cry. I do this every time I talk about the pandemic and the work that's been done by public health, but fortunately you're not here in the room to see me. I want to acknowledge the gratitude I have for the public health staff statewide. They have worked tirelessly, testing, vaccinating, coordinating isolation and quarantine orders, working with schools, working with businesses. It's been extremely challenging at every level. I cannot tell you how challenging it has been. If you see the faces in this room, you can tell it has been challenging for everyone. Public health workers are exhausted, just like hospital and other healthcare workers, but I just don't think public health is visible to the public or even policymakers. And often because we're doing things that aren't necessarily valued, like telling people to be quarantined or telling people to be isolated or telling people to wear a mask, we're not only not valued, we're ridiculed, we're lambasted in social media, or as happened at several of our testing sites, booed and jeered to the point that our vaccination sites rather had to close. This is absolutely unprecedented in my public health experience. And I have never experienced anything like that myself personally or to my staff. As I've gone around the state, visiting the various county health departments, I could see the burnout and fatigue on the faces of the epidemiologists, the nurses, the other staff. And I think that we really have to think, how can we continue to support our staff even as we continue to fight a pandemic? In a study of state and local public health workers done by CDC, 53% of public health workers reported symptoms of at least one mental health condition, including depression, anxiety, or PTSD. I take those results very seriously. We have to ensure that we give our staff the support they need moving forward, even as they may be receiving negative social media posts or other hostility. We have to ensure they feel supported, valued, and embraced for the incredible work they are doing. To me, it's a tragedy at a time that we need to recruit new people to public health, that this is the kind of reception they're getting. We have to do better, Georgia. We have to do better here in this country. But finally, to close, I want to thank all of our community partners, physicians, hospitals, churches, community-based organizations, universities, school systems, the business community, the agricultural community. But especially, I want to thank our public health team, county, district, and local. I cannot thank you enough for what you have done to protect our state in this once-in-a-lifetime crisis, and what you will continue to do to protect our state. And you will do that because you are public health. Thank you.
So thank you so much, Dr. Toomey. And I think we can all give a round of applause to the public health workers in the state of Georgia right now. And don't worry about the tears. That's a sign of humanity. We'll just buy you some waterproof masks.
Yeah, I've given up on waterproof mascara. It's hopeless.
So now we get to hear from Dr. Drenzik, I think, right?
That's right.
Thanks so much, Dr. Curran. It's a great pleasure to be here with you, with the members of the board, Commissioner Toomey, and everyone else that is able to join us today. Thank you for the opportunity. What I'd like to do in the next few minutes is really just provide a brief snapshot, if you will, of essentially the epidemiologic status of the COVID pandemic here in Georgia over the last 60 days or so, and talk a little bit about where we are and where we're going to go in the future as well. So first of all, let me just start really briefly, kind of high level with some sort of most prevalent kind of epi patterns that we've been seeing recently. So here's our snapshot as of today. So even though, again, we've had more than 1.5 million cases and over 23,000 deaths, what we are really essentially experiencing is we are in the midst of what can be noted as the Delta or fourth wave of cases. We have high transmission levels in all counties statewide, and the Delta COVID variant began spreading here in Georgia, kind of like right after the 4th of July, essentially after the first week of July or so. And since that time, we have seen a very rapid and exponential increase in cases, hospitalizations, and deaths, which has been like approximately a 60-day period or so. And when we're talking about exponential increases, I mean, we're really talking about, a 20-fold increase in cases, a 13-fold increase in hospitalizations, and a 17-fold increase in deaths since the beginning of July. Actually, over the last few days, 7 days or so, we are beginning to see some slight decreases in these, in many of these indicators. Whether that portends a longer-term trend, I cannot say with certainty, but we are hoping so. But if we take a look at these past 60 days, the most significant epidemiologic trend that we have seen that was much different than previous waves of this pandemic is the tremendous impact that we have seen on school-age children. And that is in all of our surveillance indicators, both cases, hospitalizations, and even deaths. And as a matter of fact, as an extension of that impact, we are seeing that, over these last several weeks, we've had about 60% of all of our COVID outbreaks are occurring in K through 12 schools, which is about a 7-fold increase than it had been even in previous waves of this pandemic. And, all of this fourth wave is going on in the face of vaccination efforts that continue. Many of, as the previous waves of our pandemic, did not have the luxury of having a vaccine available. And this one, again, which has exceeded all of the other peaks together, has vaccine. We have about 53% of all Georgians that are now have had at least one dose of COVID vaccine. So we still, indeed have 47% that have not. And the good news, though, is that when we are looking at among individuals that are vaccinated, even though we've seen these great increases in cases, hospitalizations, and deaths, when we look at the severe outcomes, when we look at deaths and hospitalizations, nearly all of them have occurred among unvaccinated individuals. So, greater than 99.9%. And I'll show you some numbers about that in a bit. So this is our overall snapshot. Now, let me just really rapidly sort of guide you through a little bit of a dive. Pictures actually speak louder than these words on this slide, and you can really see how different this wave looks. And we'll start to look at the different surveillance indicators in a little more detail. So let's start with total cases. So this is just an epi curve that shows the number of cases over time. And as you see, essentially the humps in the graph, these are really our 4 waves, starting way back in 2020. And if you look at July 1st, this is about when we started to see our Delta wave, essentially. So to the far right, this peak, look at how significant, really, when you take a look at this wave. So the rapidity with which these cases ascended is, again, much, much quicker, much steeper than we saw in our late December and January peak. If you look at this way, it's much spread out, building up over a longer period of time. But look at this one, it's like straight up to high levels, beyond what we saw even in January. So that's how transmissible this Delta variant is, and really resulting in this very, high levels of spread and transmission all around the state. So when you take a look at, that's just kind of the big picture of cases. Now let's take a look at the big picture of COVID deaths as well. This surveillance indicator, usually deaths follow cases by a couple of weeks or so, meaning, individuals get infected, they go on to develop a more severe illness and end up getting hospitalized and then dying. And so it usually follows our case patterns by just a couple of weeks. And so you can see here, again, at the far right, this peak is, again, approaching kind of some of our peak levels that we saw in January, not quite as high, again, expecting protection from, some of our population that has indeed been vaccinated. But if you start to take a look at, again, the tip here, and if you start to look at these death numbers, I think if I can tell you a little bit about, if I tell you the number of deaths that we recorded in July was almost 500. The number of deaths that we recorded in all of August was over 1,600. And the number of deaths that we recorded in September in the first 2 weeks were well over 2,000. So that shows you, again, this steep incline in these number of deaths that continue to rise. We're starting to see a little bit of a dip as well. So whether, again, this holds, I'm hoping so as well. But again, a staggering number of deaths in a very short period of time. Hospitalization, same thing. So you've seen each of these main surveillance indicators, and you've seen the graphs that look almost exactly the same. It's cases, deaths, hospitalizations. This is a census, meaning a daily census of the number of patients that are hospitalized with COVID on any given day. And as you can see, over the same July, rapid ascent up to a peak that's higher. Our previous peak was in early January of around 5,700 total patients hospitalized all around Georgia with COVID. We hit 6,000 on September the 7th, and we're starting to go down just a little bit. Today's count was about 5,500. So again, we're very much at peak levels, even though we're starting to go down. So I always caution that even though we may be starting to see the beginnings of some declines, look at these high levels where we're starting from. It's certainly still very indicative of a lot of strain in the hospital system, a lot of strain, again, in the school system, and plenty of risk of transmission in communities as well. So let's just take a quick look at age group. If I talked about our biggest epi pattern that we saw in this fourth wave or this Delta wave was that the impact on children. I want to show you how this looks. So this graph actually, if you take a peek at the age groups, if you see the red line, those are adults 30 to 59. So, you know, young to middle-aged adults. They've always comprised our highest case numbers in every wave. Those adults are always, you know, sort of number one. But if you look at children, which are in blue, they've always been way at the bottom, lowest level, lowest number of cases all along. They've comprised less than, you know, historically, 10% of our total case numbers. And now, here's our wave. Look at this blue line way up here now. So children have, you know, really bolted up into really the second spot, and they really comprise more than a quarter of all of our cases now as well. Tremendous impact in children, much, much different than the other parts the other waves of the pandemic. Now let's break down this children wave into what age of children are we actually looking at. So we can take a peek here. Here we are. Look at this. It's huge. So this purple line, these are kids 10 to 17. So again, certainly the ones that are 12 and over are eligible for vaccination. But so this is, you know, sort of, you know, not little, you know, little elementary kids necessarily, but more like middle school, high school. Huge numbers here. Huge numbers here. These are 5 to 9-year-olds in red, and these are 1 to 4-year-olds in yellow, and these are infants under the age of 1. So again, so you see this huge, really impact, even though we're starting to go down now a little bit too. But I think that really the magnitude of this, of the number of cases here in this age group among school children, you know, is very significant. And the result of having all those cases in school-age children is having many, many outbreaks in K-12 schools. So again, if you kind of look, this picture probably looks a lot like the other ones as well, but this really just shows you kind of the number of outbreaks per week. I mean, we were hitting over 100 outbreaks in schools, you know, in a given week, you know, recently. So again, and about in this past week, typically we've been seeing over 60% of all of our outbreaks are occurring in schools. So again, there's a lot of transmission in this, it can be in these school settings. And again, obviously not all school-age children are eligible for vaccination, but many are, and maybe some of these cases could indeed be prevented. And as really kind of one of my, you know, this is really the tragedy of what's going on with this epi pattern, seeing this many cases among children, is that we really are going to, unfortunately, have, you know, some that result in severe outcomes, either hospitalization or death. And if you look at, again, these graphs, the left one shows you hospitalizations. And again, this increase here, this gray line, is primarily among school-age children, 5 to 17 years of age in this exact same time frame. This middle line, the gold one, are college-age kids. So again, we saw the numbers. Take a look at this, the y-axis. Check if these are counts. So the numbers are low. Like here we are, like 70, 80 children hospitalized, you know, as this graph goes up. But regardless, you know, again, these could potentially be preventable and tragically, you know, result in these increases as well. And as far as deaths go on the right, you know, we have been recording some occasional pediatric deaths throughout the pandemic. But in August, we actually confirmed a total of 4 confirmed deaths among pediatric patients in August, higher than any other month. So again, we really are, you know, seeing this tremendous impact of this Delta wave in this school-age population. What can we do about it? We are, vaccination is certainly a key mitigation effort. And if you take a look at how we as a state are doing in these age groups, you can really it really supports the picture very well. Sort of if we're looking at increasing vaccination rates over time, these increases are subtle, right, over this whole period from January on. And again, wouldn't we love to see the vaccination rates go as high up and very steeply like those other epi curves, but they do go up. I mean, we are seeing increases over time. We vaccinated lots of people over time. Clearly, the older folks, 88% are vaccinated over the age of 65. But if you take a look at right in the middle, the green and purple, these are, again, school-age kids too. So the green, school age and college age. So that purple line is 14 to 17, and then the blue line is 11 to 13 years old. It's only 25% there. So that would typically be, 12 and 13-year-olds, clearly. But again, lots of opportunity to perhaps improve vaccination rates in children that may provide some protection along with other mitigation strategies. So our vaccination efforts will continue. You'll hear Dr. Rustin talk a lot about all of the things that we're doing to improve and outreach to improve these numbers as well. And we're doing great in the sense that if you take a look at this slide, this is published on our website if you want to take a closer look at it. We often get asked questions about among individuals that are fully vaccinated, it is with that much transmission of Delta going on, it's natural that, no vaccine is 100% protective, known. So you're going to get some individuals that get infected, even though they're vaccinated. But look at the numbers. They're stunningly low, honestly. The vaccine is working extremely well. We've got almost 4.6 million people fully vaccinated. I'm talking from the circle on the right. And of them, about 40,000 tested positive or have a COVID infection. So again, less than 1%. And of those individuals, about 1,400 were hospitalized and 277 died. So again, certainly, every hospitalization, severe outcome, and death is tragic. However, when you sort of look at these numbers and the magnitude and the scale, again, we're talking way, 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 way less than 1%. So the vaccine is working exceedingly well in protection, particularly against severe outcomes. So we have to continue to focus these efforts. And if you take a look at the other side of the coin, the non-vaccinated people, these proportions are much, much greater, even 20 times greater. So we are very grateful to have the availability of the vaccine and will continue to promote it. And Dr. Rustin will tell you all about that. And in summary, as I just sort of conclude all that I've shown, that I think, again, was, kind of very compelling about what's different now, is that this Delta variant is highly contagious, and it spread very rapidly in Georgia in a period of about 60 days or so, in the face of a population that, half of the population is not fully vaccinated. This fourth wave surpassed really our previous January peaks in regards to all of our surveillance indicators, cases, hospitalizations, and deaths. And the most significant epidemiologic pattern that we have seen recently is the severe impact on school-aged children, also resulting in these exponential increases, across the board in all of these surveillance indicators. We are beginning to see some slight declines in many of our surveillance indicators over the past 7 days. This is consistent with other states and other nations that have experienced Delta surges or Delta waves. After a period of about 60 days or so, it is typical to start to begin to see some declines, but by no means does this mean that we have nothing to worry about. We are beginning to see some declines from a level that is beyond where we have ever been before, certainly indicative of the potential for high risks of transmission. So we still need all of our, sort of arsenal of mitigation measures, beginning with vaccination as our primary, and also the adjuncts as masks, social distancing, staying home when sick or potentially exposed to someone with COVID are critical for continuing these declines. And I think that's it for me. Thank you all so very much for your kind attention. And if you have any questions, I'm happy to take them out by email, or I guess we're not going to have questions necessarily during the meeting, so.
From the board.
From the board, of
Yeah.
course, yeah. Thanks so much.
I think we have time for a few finite number of questions from the board for Dr. Drensick. So just speak up or raise your hand. I'm not sure how to raise your hand, so just speak up. So Dr. Drensick, one just additional comment. The very high vaccination rates among the elderly, and particularly those in nursing homes and disabled, indicates that the surge in hospitalization and death have a much lower average age than in the past. It's no longer just a total disease of the elderly. Can you comment on that?
Yeah, that's a very good point, and indeed that is the case. So not only are we seeing increases in hospitalizations in kids, as I had mentioned, but really we also are, everything is trending younger, sort of in the whole age group younger. Our hospitalizations, sort of if you look at the median, it's in the 50s, versus where it was before among, individuals that are over the age of 65. So again, the fact that we would like to increase vaccination rates among sort of all age groups still remains prevalent for this particular situation too, and we have these individuals that are being hospitalized and subject to severe outcomes too. So thank you for that.
Dr. Curran?
Yes.
Yeah, this is Kathleen. I think you'll appreciate this. I mean, there was a couple of weeks ago where there are so many people I either knew personally or relatives of people with whom I'm working here who had deaths in the family, all young people, and frankly, all young men. I almost had a sense I was back in San Francisco in the 80s, practicing at San Francisco General in the early HIV epidemic before we had anything but testing. It was a bizarre PTSD moment for me, remembering another time when you feel helpless in the face of so many deaths and not able to turn that around despite an effective vaccine.
Yeah, I've been recurringly amazed at how political COVID has been. It's just hard for me to see why all people who've been reluctant to get an adult vaccine for shingles or influenza don't feel differently about COVID. But I think more and more people are having that experience of seeing their friends die. But there's still a number of people who don't believe in viruses or vaccines. And, it's always uncertain when politics gets involved, whether it's, President Biden issuing mandates or Governor DeSantis and prohibiting mandates to see whether that's effective or ineffective. But I just don't understand why everybody in the country is not running off to get vaccinated. I guess I'm just naive. Well, thank you, Dr. Drensick. Now we have Dr. Rustin, who's going to tell us what is going on.
Hey, good. I can't wait to hear.
So I believe someone's going to advance my slides. I'm not in the room with the group. So thank you. First of all, Chairman Curran and the board, it's a pleasure to be here, Dr. Toomey, to present a few of the operational updates. And some of this will support Dr. Drensick's presentation as well. So before we kind of dig into that, I want to do a quick look back. This was just a few short months ago, it seems longer, but just back in January of 2021, as you all remember, we were all under this population-based allocation system due to the limitations on the vaccine supply. We don't really have that problem now, but it sort of brings things in full circle. At that time, our state chose a risk-based sort of phased approach to vaccine distribution, and the chart that's in the bottom right actually shows those phases. In the very beginning, we prioritized our highest risk individuals, healthcare workers, first responders, and individuals and caregivers that were in long-term care facilities. Quickly in January, we added the over 65 population, and then a few weeks later we added the additional educators and staff, and then eventually adults with intellectual and developmental disabilities and their caregivers, and then parents of children with complex medical conditions. And I believe that is reflective of the data that Sherry just showed, in which the older population is our highest vaccinated population. And it was really a strategy that this state chose that I think was operationalized pretty well. But in the beginning, we were literally, in the very beginning, allocating vaccine by hand. We were using spreadsheets and quickly learned that this was not sustainable. And we brought on a team of data scientists to help us develop an allocation model. So in the very beginning, we were equitably allocating vaccine across the state. This particular model looked at on-hand inventory, administration rates, requests for vaccine. It also heavily prioritized social vulnerability index and population demographics to ensure that we were placing vaccine in locations that had the highest need. Next slide, please. Next slide. Thank you. Just to kind of give you a little bit more of the vaccine statistics, as Sherry had mentioned, 53% of our population has received at least one dose. But to put some numbers behind that, as of 9/14, as of today, over 10 million doses have been administered in the state of Georgia. I look back to January and I remember when we were getting excited over a few thousand doses administered. And now we broke the 10 million mark this past couple of weeks. As 53% of first doses have been administered, that's over 5.4 million doses, and currently over 4.7 million individuals are fully vaccinated, or 45% in the state. When you break that down proportionally by type of vaccine, you can see that the majority of the vaccine administered has been Pfizer. About 58% of the vaccine has been Pfizer, but also that's the only vaccine currently authorized or approved for adolescents and teens as well. So that's to be expected. About 40% is Moderna, and then about 2% is Johnson & Johnson. And just to graphically show a different age bracket, you can see below the percentage of individuals vaccinated on the bar chart. And the 55 and up is, again, our highest vaccinated individuals. Next slide, please. Our COVID vaccine providers is really a broad mix of providers across the state. We currently have over 5,000 COVID providers statewide. These providers are made up of our health departments, our hospitals, primary care providers, pediatricians, federally qualified health centers, pharmacies. In the beginning, we really prioritized pharmacies because there's such a large number of pharmacies that we were trying to get vaccine across the state as quickly as possible. So we have literally hundreds, if not thousands, of pharmacies that are providers. Also, colleges, long-term care facilities, our correctional facilities, and dialysis centers, just to name a few sort of the mix of vaccine providers. But one thing that we're working on is sort of a new recruitment campaign to try to bring in more primary care providers. Next slide, please. DPH's goal, Dr. Toomey's goal, is to really normalize COVID vaccination in primary care offices. We believe strongly that this will help increase vaccination rates because time and time again, surveys show that the public feels that primary care providers are the most trusted source of medical information, and we want to make sure that this process becomes normalized within the practice. What we're doing right now is sort of a new recruitment campaign to get more primary care providers by partnering with the various Georgia medical associations. This campaign will focus on first surveying to ascertain some of the challenges. Anecdotally, we've heard a lot of the challenges is related to storage of the vaccine, of having sufficient space to be able to have people wait for the 15-minute or 30-minute post-shot wait period, staffing issues, IT issues. So we know there's challenges out there, but we're working to survey various primary care providers to learn more about that. But also we want to offer webinars that includes some CME credit to try to encourage providers to learn about the enrollment process and how they can become, part of this process of normalizing the vaccinations within their practice. We're developing additional patient and provider resources. And the one thing I want to highlight is this small vaccine package, logistics and distribution. This is something that was an idea of Dr. Toomey's after discussing this with CDC and the vaccine manufacturers to try to encourage more small providers to become enrolled to offer this vaccine. So next slide, please. One thing that many people may know, a lot of the public may not know, is that Pfizer, which is currently, again, the only vaccine that's authorized in ages 12 and 15 for adolescents as well, and actually approved for anyone 16 and older, it actually gets shipped in very large packages. The current packaging right now is 1,170 doses minimum or 450 dose minimum packaging. The picture on the right shows actually one of the trays of 1,170 doses, which is 195 vials roughly. Most small providers, due to storage issues, due to not seeing enough patients, really struggle with being able to handle that volume of vaccine at a given time. And so after reaching out to the manufacturers, to CDC, to see if there was a way to convince the manufacturers to reduce the packaging size, we just decided at the department that this is something that we could do ourselves. The Department of Public Health has a warehouse and storage facility that we store and distribute various types of items to support this pandemic. And one thing we also do is store emergency supplies of vaccine at this particular site. And so the team developed a way to break these packages down into much smaller, more manageable units. And you can see the picture on the right, far right, is a small box of Pfizer that has come in as a request from a provider. And so we decided to offer 120 dose or 60 dose packaging to allow the smaller providers to be able to offer this within their practice and not be concerned about wasting doses or having storage issues of this particular vaccine. We've added probably 40 to 50 pediatricians by offering this new process. We receive anywhere from 30 to 45 different requests a week for much smaller packaging. And our team on an every week basis repackages this vaccine. And through our partners with DNR as well as the Georgia State Patrol, we redistribute this packaging out to the various providers across the state. Again, our goal is to increase the number of primary care providers by making this much more manageable within their practice. And we hope that as we share this information more, it will encourage more of these providers to want to enroll and offer this vaccination within their clinic. So I want to really thank the team and Dr. Toomey's vision on this particular process. They've done a really stellar job of developing this process for us within Georgia. Next slide, please.
Can I just do a shout out to all of you and particularly at the warehouse, because I tried everything I could. I even wrote letters to Dr. Walensky and said, you've got to use your influence to get Pfizer to do smaller packages. And we just consistently got back, the manufacturers can't do it. And for whatever reason, it was financially impossible. And then it ended up, we were able to do it ourselves efficiently, easily, and I was able to share what we're doing with all the other Southern health commissioners because I work with them very closely. So in the end, we took the bull by the horns and ran with it. I'm mixing my metaphors, but we were able to accomplish what we tried to do easily and efficiently. And many thanks to everyone in the warehouse and the National Guard who were an essential part of that repackaging.
Absolutely, and actually the picture that you see on the far right is one of the National Guard's women that is assigned to the warehouse, so it's absolutely appreciate their support in this effort. We really could not have done it without their support. Next slide, please. Again, our vaccine outreach efforts, this is just a few examples. You know, there's been so many different outreach efforts that have occurred throughout the state with our various health departments. I do want to highlight on a few of these efforts that have occurred at the state level, but do want to recognize that many of these outreach efforts are occurring on the ground locally through the health departments and being operationalized locally through the health departments. But we do have a Health Equity Council that has assisted the department with vaccinating many of the hard to reach communities We've done many events in the Latinx community. We partnered with African American churches and had some really successful events across the state, providing vaccination to individuals that may have been somewhat hesitant, but we were able to bring the vaccine locally to them in settings that they felt more comfortable in getting vaccinated. Early on in the pandemic, we partnered with the Chamber of Commerce to try to get the business community involved. I think the message from us as healthy employees, ensures that businesses are able to stay open. And so partnering with the Chamber and continuing to partner with the Chamber is a very important outreach effort of the department. But also we partnered very closely with the Georgia Poultry Federation. I believe the poultry industry is one of the largest, if not the largest, agricultural commodity in our state. And ensuring that this industry was able to stay open and operating not only impacts the industry itself, but it keeps farms going, it keeps the workers employed. And so we partnered early on with them to offer a large number of vaccine clinics within the poultry setting, within the actual poultry plants. Many of these events occurred during shift changes at early hours in the morning. And so again, want to thank our partners through the Georgia Poultry Federation for assisting us with that and helping us get vaccine into the arms of these workers. And then the Department of Agriculture and Farmers, a lot of work has went into partnering with Department of Ag and the farmers all over the state, especially in South Georgia, where there's a lot of migrant farmers that pick blueberries or onions, or whatever the various commodities are that have to be, whatever crop has to be picked. We wanted to be able to move very quickly to offer this vaccine to them so they could continue operating and not having outbreaks within their employees. We partnered with a company called Viral Solutions to offer vaccination clinics within our jail setting, and I'll talk a little bit more about that in an additional slide. We work very closely with providing transportation services for those with developmental disabilities to and from our vaccine sites. In addition, our former CMO, Dr. Peacock, had set up several developmental disability clinics that focused on that population and offered them vaccines. We've worked very closely with our health departments to implement nursing strike teams that reaches the hard-to-reach population, primarily the homeless or the homebound population. We actually have a link on our website where people who are homebound who need a vaccine can request that, and it gets assigned to the proper health department or health district so they can send a team out to offer that vaccination to that person within their home. And then lastly, I want to mention a partnership with Community Organized Relief Effort known as CORE, which has really assisted us with our statewide mobile vaccination efforts across the state. In addition to our health departments who are also offering various mobile vaccinations and going out into the community, we wanted to strategically partner with CORE and have them become part of our system of offering vaccinations in smaller settings within the community and making it very convenient for the public to get vaccinated. Next slide. So I'll first focus on CORE. Again, CORE has been with us since around March. They actually have been with a lot of the metro health departments offering testing going back into the early 2020s. But we started partnering with them in early March to offer vaccinations. CORE is very mobile. In fact, their entire model is built around mobile. They have an operation team in Metro Atlanta. Actually, they work out of the Fulton County Health Department. But then they have teams scattered all over the state of Georgia in our public health districts offering clinics within the community. Sometimes they only see 10 to 15 people. Sometimes they see hundreds of people. But we feel like every opportunity is not wasted if we can get a shot in an arm. But I do provide you a few statistics from CORE that they recently provided to me. Since we partnered with them at the department since early March, they've done over 2,000, almost 2,100 events across the state for us. And these have been across 639 unique sites across the state. And on our behalf, they've administered over 54,000 vaccines, and that number is higher today because there's over 100 teams out today across the community. If you break this down and look at some of the demographics, you can see that they typically reach a younger population. They typically go into areas that have more younger people. They go to work sites. That's why you see some of these are probably working age individuals. They're just a very nimble organization that's able to go into areas very quickly and rapidly, stand up very fast, and offer vaccines to the community. And they've been really good to work with across the state and across our various districts. Next slide, please. As I mentioned earlier, we decided early on that we were missing a population within the jail and correctional facilities, and we wanted to bring on a vendor to assist us with that particular population. And so we partnered with a vendor called Viral Solutions. They had originally began assisting us primarily in jails, which across the state of Georgia is primarily under the auspices of the local sheriffs. But they've recently started working with the state corrections facilities as well, offering vaccinations in state corrections facilities. Early on, we worked closely with state corrections to get them enrolled. They were vaccinating inmates within their facilities. And as of July 16th, based off of the Board of Corrections data, they vaccinated over 29,000 inmates across the state. When the department contracted with Viral Solutions for jails, since a few months ago, they have been able to vaccinate almost 14,000 inmates in local jails, and around 310 staff have been vaccinated across the state. And this team, again, is very nimble. They go in and out of the jails. When they go to the jails, they offer the 3 different vaccines. They set up second dose clinics when needed. And they are recently partnered with the State Board of Corrections and are now doing vaccinations within the Board of Corrections as well. Next slide, please. We'll give a brief update on monoclonal antibodies. There's been a lot of discussion about monoclonal antibodies, and basically, for those that are not familiar, monoclonal antibodies are essentially laboratory-made proteins that mimic the immune system's ability to fight off different kinds of antigens or viruses. The thing that I want to mention is really highlight is laboratory-made proteins, because there seems to be some confusion around this being sort of a natural treatment when in actuality it is made within a laboratory. The thing, though, that we've seen and what the data tends to suggest is that for this to be even remotely helpful, you have to really offer this treatment early on, within 10 days or less of symptoms. And, you know, the data is still out there. It is very much an emergency use treatment. And one thing the department is doing is collaborating with our sister agency, Department of Community Health, to try to support existing sites across the state that are offering this treatment. And we've recently learned from HHS that we will be helping coordinate more of this across the state as they start putting states on allocation. But the one thing I do want to highlight more than anything is that this is not a substitute for vaccination. I think that we can say that enough, that we strongly encourage people, based off the data that Dr. Drenzik showed earlier, to consider vaccination as the primary way to prevent and reduce severe illness and death from this particular virus. The map on the right just shows an example of sites across the state that are offering monoclonal antibodies. It's really a snapshot in time because this map just maps locations that have been shipped to. New locations may have or monoclonal shipped to since this map was made, but it does demonstrate that there is sites all across the state in all regions of the state. Next slide, please. I believe this is the last slide I'm going to leave you with. It's COVID testing. As Dr. Drenzik had mentioned, we've really focused a lot on COVID vaccination, as we should, but we can't forget about testing, because it's important that we are able to see what the trend is out there in positivity rates. And the department, through its health departments, are still offering testing across the state to recognize that the local health departments needed assistance so they could focus on vaccinations. The department brought on a vendor called Mako Medical back in January to assist the local health departments with offering testing across the state. And currently, our Mako Medical has over 43 sites across the state. We call them SPOCs, Specimen Point of Collection Sites. These 43 sites offer free testing in all regions of the state, and we currently encourage the public, if they are having symptoms or think they've been exposed, that they get tested. Due to the surge in Delta and the pressure placed on our local hospital emergency rooms, we decided to bring on an additional vendor to help ease the burden on the hospitals. This vendor is called LTS, and we have really partnered with hospitals across the state to stand up collaborative testing sites on hospital campuses or adjacent to hospital campuses. And currently we have 16 of these sites on hospital campuses or adjacent to them stood up across the state, and by the end of this week we'll have 5 additional testing sites stood up. And the primary goal is to ease the burden on the emergency room so individuals aren't showing up to the ER to seek testing, and this is an alternative place on the campus for individuals to seek testing. In addition to that, there's a litany of options across the state in the private sector. I do highlight Walgreens because they are a federal funded pharmacy. You can get free COVID testing at Walgreens through the federal program, but testing is also being offered at urgent care facilities, at other pharmacies, at doctors' offices all across Georgia. And just a little bit of the statistics you can see, as of yesterday, over 11 million tests have been conducted, at least that has been reported to the department through the ELR, that over 11 million of those tests have been reported. And the overall positivity rate of these tests is around 10.5%. But as you can see, when you break that down by reported today, PCR test is around 17.2%, and antigen test is around 10%. Next slide. And with that, that's my last slide. And again, I can take questions as well. Thank you.
Thanks, Dr. Rustin. Are any questions for him?
Some of you heard that Dr. Rustin moved back to Savannah. Well, he did, but then right around Christmas time, I called him and I said, we really need you. And I got permission from Mrs. Rustin, and so he's here leading the charge.
Thanks for doing that, Chris.
My pleasure.
The relaxing atmosphere of Savannah awaits you eventually.
The high numbers of COVID in Savannah await you eventually.
Yes.
I'm sure she pointed that out when she recruited you. It is safe to be in Savannah. Now I guess we move to Nancy Needham.
Thank you, Dr. Curran, members of the board, Commissioner Toomey, and others. I want to share some of the things the communications team has been doing to support the DPH response effort to COVID-19. When we go back to February of last year, it became obvious very quickly that this was going to be unlike any other response that we had done. It was also going to be different than any other media educational campaign we had ever done. So one of the first things we did was we looked at the types of communications we needed to do and the audiences we needed to address. We quickly bucketed those out into public communications, provider communications, and partner collaborations. We started with traditional news releases, interviews, news conferences, but we also knew that we were going to have some new tactics, some new tools, and to make all use of new technology to get our messaging out. We had to do a very quick website redesign to include all of the guidance and information that was coming out, and we continue to do that almost on a daily basis as information and guidance changes, and we add more things to the website that are hopefully helpful to the general public in securing testing, vaccinations, or just general information. We've also added to the website, as you know, 2 big databases. One of them is for vaccinations. The other is for our testing and case numbers. Those have also expanded and developed over the last year and a half as we've been able to add more data by county and demographics. So when we look back where we began, our three basic messages were around testing, contact tracing, COVID information, and prevention. And these are just some of the places that we started. We certainly had an external marketing campaign with billboards in the airports, in newspapers. We also, for the first time, made use of banners that were located in grocery stores promoting both testing and contact tracing. So as COVID continued to evolve and as we got closer to having a vaccine, we knew that our messaging was also going to have to evolve. And our graphic designer said to me, you know, I'm tired of telling people what to do. We've told them to wash their hands. We've told them to wear a mask. We've told them to stay 6 feet apart from others. We've told them to get flu shots. I think we've told them enough things to do. So she came up with this idea of, I said yes, and it was basically to let people share their reasons for saying yes to the COVID vaccine that was now available. So we've had many, many different opportunities as we've expanded this campaign. Some of them I never anticipated. For one thing, the thought of having being center stage at Atlanta Motor Speedway was something all new to us. I think it was all new to Atlanta Motor Speedway too. We've made use of some of our partners with CVS by including vaccine information in pharmacy, the bags that you get when you purchase anything at the pharmacy. But then we've also worked very closely with the independent pharmacies, many of them in some smaller rural communities, some of them that have very, very close relationships with their customers and know them by name when they walk through the door. And we put that messaging also on the pharmacy bags that they actually get their prescriptions in. And those messages were tailored to meet all different demographics. We tried to emphasize not only the safety and the efficacy of vaccination, but some of the more emotional reasons for getting a vaccine, such as spending time with family, spending time with grandchildren. It was interesting and continues to be so that in previous campaigns that we've done, whether it was for HIV or prenatal care, that you always had a specific demographic and you tailored your message to that demographic and the areas of hotspots. And I think what was very clear and is very clear to us now is that we don't have those smaller demographic areas or that smaller target audience. Just about everything we're doing and saying affects everybody in the state, regardless of what age they are. So that's another very big difference in what we've done in the last year and a half compared to some of the other smaller campaigns. We certainly upped our game on the web and social media, both by boosting content, which is actually paid content. We did a couple of different series of information. One was on truth versus myths about COVID. We've been able to tailor our messages to the Black community, to Hispanic communities. Everything we do is in Spanish and in English. Many of the districts have also included other languages depending on their own populations and demographics there. One of the things we recently were able to do was Kirby Smart did a vaccination video for us promoting vaccination among all Georgians, specifically the Dog Nation. I'm not sure how well that message is getting across, given I know that they've got a lot of team members and staff members right now that are sick. And we are working to bring on the other coaches from some of the other schools in Georgia, but UGA was front and center and has been a great partner with us on many things. One of the other video series that we did was something we call Ask an Expert. And you see the expert in the middle there, Dr. Drenzik, who we picked on first to talk about COVID and the variants. But we also have covered why get a COVID vaccine, COVID vaccination for children, women in vaccination, COVID vaccine and the side effects, and COVID vaccination that we provided information in Spanish. And we were able to get really, really great input and help with many partners around the state. And I'm really happy to say that we are working on another round of these, and it gives us the opportunity to bring in physicians from different districts, different parts of the state, so that people can feel included and know that, you know, oh, this is a Savannah doctor or this is a Columbus doctor. We have found, as I'm sure you're aware, that in repeated surveys, focus groups that we've done, that the physicians, your personal physician, your family physician, they are the most trusted source of information. So we're trying to play off of that by putting up some of these physicians as trusted sources. The other series of videos that we have done, there are about 15 of them. They represent some general information about COVID-19. Initially, we did a video explaining the vaccines, the different types of vaccines, the science behind those vaccines. We've done videos on contact tracing, and then also a video that was targeted toward the elderly, and things that they needed to know before they went to get their vaccine, even things they needed to know before they went to get a test. And our print collateral really runs the gambit. We've done posters, we've done information cards, we've done cards that can be used and passed out at testing sites, at vaccination sites that talk about any potential side effects. One of the earliest pieces that we did was that Box It In, which was basically testing, isolating, locating contacts, and quarantining. The Say Yes in the lower right-hand corner has that image on the front, and those are that's an actual gentleman who came in to get a test and a public health nurse from the coastal district. We also have one in Spanish, again, with someone who actually came in to get a vaccine and one of our public health nurses. And on the back of that, there are just some very general facts about the vaccination that we're working to dispel many of the questions, many of the misinformation that people had about the vaccines, that they would put chips in you, that your DNA would be changed, that you would get COVID from the vaccine, all that information to help dispel some of that misinformation that was circulating. One of the biggest challenges when we're talking about print, obviously, is the fact that the information is constantly changing, constantly updating. So that's something that we're always tweaking and always working on. We've been very successful in this campaign in getting TV spots produced. We've worked with WSB and WXIA specifically on producing some TV spots that have aired. We've also been very, very fortunate of the placement of some of those ads airing in the Academy Awards, the NBA Draft, the Olympics, Peachtree Road Race. We're now currently working with Fox 5 on some spots that will air during Falcons games. The other thing, we're also working with the districts right now to increase their participation so that they can do more targeted information in their districts. We've done all statewide buys on all of this collateral. where it's available. Not everybody has transit available, but we've done statewide buys, but we need the districts to also work with us to get this messaging out in more than just the places where we are. Some of the districts have already jumped into the fray on this and have taken the model of I said yes and tailored it so that they can use some of their own local community leaders on those billboards, giving their reasons for saying yes to the vaccine. This is an event, the Say Yes Summer Series is something that we just recently rolled out. We started it in 3 pilot locations in Savannah, Athens, and Atlanta. And basically, it was a unique opportunity to combine COVID vaccinations and information with arts and culture. Depending on which location you were at, we had various types of live music or a DJ. We got local artists to do their artwork live and make it participatory with people who were coming to these sites. We were at the Forsyth Farmers Market in Savannah and the Bacon Bananas. Is that right?
Savannah Bananas.
Savannah Bananas. I knew something wasn't rolling off my tongue quite right. At the Savannah Bananas. In Athens, we set up a location at the Tate Center, the Student Health Center at UGA, and then the big bike race that they have, a 2-day event. And then we were also at the aquarium for 2 days, encouraging people there coming to the aquarium to get vaccinated. One of the other components of Say Yes Summer Series was we created this cube, and it was basically a big chalkboard where people could write down their own reasons for saying yes to the COVID vaccine, and that was really, really a success. People liked doing it. I was very happy to see that most people played by the rules. We didn't have many that we had to edit or redact from the board, but it was a great way to get them participating. I was also struck, and I know Dr. Rustin said the same thing when he was in Savannah at their events. I was really struck by how there were so many people who would come by and simply want to talk to you. They may or may not be ready to get a vaccine, but it was that one-on-one personal conversation. And even better to report is the fact that in many of those situations, the individual or the individuals would come back in 30 minutes or after they had done whatever they were going to do at the market or at the aquarium and said, okay, yep, we're ready to do this now. So it just struck me that this personal one-on-one conversation was so important. If we didn't do anything else, that in and of itself was certainly worth the time and effort that we put into these. So going back to what I said originally in the buckets of who we needed to target, providers, of course, there was a lot of information to get to providers. There still is information to get to providers. But we also realized that, again, because these providers, these physicians, were the people that are constantly noted as being that trusted source of information, that getting messaging out to Georgians, regardless of where they are, a lot of it had to do with the healthcare providers. So we've provided them not only with letters from the commissioner with updates about different COVID aspects. We've done provider webinars. We've provided specific messaging that they can use with patients when they talk to them about vaccine, even if they're not a vaccine provider right now, as long as they're talking to their patients and encouraging them to be vaccinated. And we've also communicated important information about the GRIT system and the newer vaccine management system, just to make sure that we were getting updated, timely information, and that if there were questions, we could address them quickly, since all of that data eventually flows into those dashboards that I talked about earlier on our website. And I would be totally remiss if I didn't mention all the communications we've done and the collaboration we've done with many of our partners. Chris mentioned some of them in the business communities, the agricultural communities. And again, this is a place where we've been able to provide messaging guidance, toolkits for their use that include much of that collateral that I showed you. We've worked closely with the PIOs in the various health districts, had bi-week or twice a month meetings with them to share some of their best practices, to share things they've learned on the ground. It's a little different animal when you're on the ground versus here in Atlanta. So their input and their communication has been invaluable, both in the districts, but to us here too. We have compiled weekly situation reports so that we can increase visibility across the state and determine areas that we need to do additional support or address certain needs. We have done 15 webinars with more than about 1.3 thousand attendees. Those included businesses, providers, medical associations, and again, all discussing COVID-19 guidance and updates and their individual needs depending on what organization or what facility they were with. We also sent out a COVID newsletter that includes 130 plus partners to share with their communities. One of the other very important groups that we've worked with has been the faith-based communities. They have been invaluable, whether it's hosting testing sites or vaccination sites, and really working to get our message out to their individual parishioners and in their community and neighborhood, because in many cases there's such a strong presence there. We also created a health equity council that would help us reach all the demographics that we were trying to reach. And again, these are members of local communities that both have an ear to the community and eye to the community and are able to help us come up with communications that are going to be meaningful and helpful as they try to advance COVID vaccine and information in places that, quite frankly, they are far better at reaching these audiences than we are at DPH. That is, in a nutshell, what we've been doing for the last year and a half. I'm happy to take any questions.
So Nancy, I'd like to first of all thank you for the rapidity with which you've done things and also tailored it to the various populations that need. And I think you really deserve a line of thanks for us. So thanks for doing that. I have kind of a sort of a avoiding the politics question. One of the things you've done well is that you've been able to tailor a consistent message while avoiding the partisan politics issue. In other words, playing politics with the various populations needed without changing your message based upon the partisan debate. I think that we're in an era now where the vaccinated are against the unvaccinated, in the sense that we see people, for example, University of Georgia, wondering why the private universities can have stringent controls and vaccine mandates and the public universities can't, where we see a Democratic president calling for vaccine mandates and many Republicans throughout the country focusing on whether or not he has the authority to do that or whether it's taking away individual rights. So I think you need to anticipate the partisan politics of vaccine mandates to make sure that doesn't get into the way of the message of the importance of vaccines. In other words, independent of whether there needs to be a vaccine mandate, everybody should be vaccinated. And I worry that this could get tied up because I can just see the Democrats and Republicans getting their knives out again, in my view, more interested in their own reelection than they are in protecting the public health. And I'm not speaking about Georgia in particular. I'm just saying that the debate again is sounding more like Republican-Democrat politics. And the key thing is we have to get people vaccinated, independent of whether it's a mandate or not. So you should be thinking about how the mandate debate will affect your work, but not affect your message.
Absolutely. And, you know, to an extent, we've had to thread that needle certainly in the last few months, but to some extent, even since the get-go, because there were so many people, we still fight just in general, misinformation that, like Chris or someone else said, that these viruses don't exist, that COVID is all made up. It's
Fertility issues.
fertility issues.
That's the undying myth.
It's one side of the political coin, you know, creating this thing, the other side of it fighting this thing. So yeah, that's a very good point, and we will continue to do that as we navigate through this next round of whatever COVID brings us.
Well, there's no partisan politics in misinformation. Partisan politics comes in the legitimacy of the federal versus state versus local authorities. And there you have to be neutral, but you don't have to be neutral about the misinformation stuff. I mean, no partisan person would agree with misinformation regarding vaccines. Maybe about some other things, but not vaccines.
Absolutely. We'll keep it in mind.
Any other questions or comments for Ms. Needham?
I mean, I think you realize how many hours of work that has required to have, and just, I mean, just the websites alone, the dashboards alone, cost people years off their life in development.
The other thing I would like to say about vaccine hesitancy is that not only do we have the anti-vax movement, but the country has never liked adult vaccines very much. I mean, look at our adult vaccination rates for pneumococcal infection, shingles, influenza. I mean, we can't expect the kind of vaccination rates that we get among entry to school people. And then the second thing is a large number of populations, and maybe even more now than 20 years ago, distrust government and distrust various parts of our population. And so winning them over to trust us is an expected problem that Nancy and the group have really been working on. So thanks again. Can we hear about legislation from Megan Andrews?
Yeah, it's nonpartisan.
I know. I'll be a palate cleanser from all the COVID talk. I'm going to give you all an update on this past legislative session and go through the bills that received final passage. I usually categorize them into two buckets. The first being direct impact bills, which require us as an agency to do something differently. So there's some implementation that has to happen following session. And then the other bucket being bills of interest, things that touch on our subject areas that, you know, our programs would be interested in, but we don't necessarily need to do anything differently following session. So I'm just going to cover the direct impact bills that received final passage this year, as well as some budget items that passed that I think would be of interest to you all. So the first bill is House Bill 146, which provides paid parental leave for eligible state employees. That bill received final passage, so now state employees get 3 weeks of paid leave following the birth or adoption of a child.
We're all smiling, you know, because you don't know it, but I do, that Megan is about to go out on maternity leave. Although I don't know if Dr. Mercer's on, I don't believe that she's going to make her due date. I think that baby's anxious to get out sooner than that.
I'll be back for session though, don't worry. The second one is House Bill 156. It changed some of our operations if we experience any sort of cyber attack, where state agencies now have to report those to Georgia FEMA, the state agency, to investigate. So that's just an internal change in procedure for our IT team. The next one is House Bill 287, which expands the course of instruction in K-12 institutions. Right now, kids are educated on tobacco and alcohol and drug use. This also, this expanded it to include vapor products. And DPH is to be involved in the development of that course curriculum with the Department of Education and a few other state agencies. So that is something else that received final passage this year. The next one is House Bill 307, which is the Georgia Telehealth Act. This implemented a lot of changes that we saw in the telehealth operations of the state due to the COVID pandemic. We have a very robust telehealth program in DPH. There's telehealth capacity in every health department around the state. So this is certainly something we were keeping a close eye on. It allows healthcare providers to provide telemedicine services from their homes, allows audio-only care in certain circumstances, particularly on like behavioral health, can now be audio-only instead of video. Prohibits requirements that patients have in-person consultations, prohibits insurance companies from charging separate deductibles for these services, prohibits insurance companies from requiring the use of a specific telehealth platform in order to reimburse the services, prohibits restrictions on prescribing of medications through telemedicine, and requires certain documentation by healthcare providers that are providing these consultations. Okay, the next one is House Bill 346. This is one that's going to take a little bit more implementation effort on our end. There's some rules and regulations that need to be adopted, but it requires all EMS personnel to be trained on congenital adrenal hyperplasia and paramedics to obtain appropriate training on how to administer hydrocortisone sodium. How do you say that?
Succinate.
Succinate. And like I said, we have to develop rules and regulations in order to implement this. So that's in process with our Office of EMS and Trauma, and our new general counsel will be working on that with that team. And it also requires the paramedics who administer that treatment to report so in the to the ambulance service that transports the patient. The next one is regarding our newborn screening committee. This codified the operations of the newborn screening committee. Previously, this was generally done through our rules and regulation and just our standard operating procedure and the bylaws of this committee. This bill kind of codified what we were already doing and set a few parameters. So when the federal recommended uniform screening panel adds another disorder to their recommended newborn screening that we should do, the committee now has a specific timeline in which to take that under consideration. They will review that condition and then make recommendations to the commissioner and the department on whether it should be added to the panel. This bill also added a requirement that after DPH approves a new disorder that we must submit a budget request to the Governor's Office of Planning and Budget for consideration in the next legislative session, seeking an appropriation in order to cover that cost of the new condition. There was also something added at the very end of session that requires various providers to give access to our maternal mortality review committee records of deceased women within 30 days of that committee's request for those records. Previously, there were no timeline requirements on that. The next is Senate Bill 32, which is just an exemption for our open records requirements. Now allowing us to redact individuals' personal mobile or wireless telephone number from any open records request. The next one is Senate Bill 46, which was a doozy. This was actually our agency bill for this year. There were several, as you can see, it kind of turned into a Christmas tree on day 39 and 40. So the first page are bills that were tacked onto it, but it did receive final passage. So the first bill will allow DPH to release de-identified data from our low THC registry to entities for research purposes. Right now, the law, well, previously, now this is in effect, but previously the law was very strict on who could get information from this registry, and we would get data requests all the time, and we were very limited on what we could or couldn't release. So that's kind of expanding the scope of what we're allowed to release from that registry. The next two bullets are both from House Bill 275. They provide for licensure and certification of various EMS personnel who are previously convicted of a felony, and provides for the creation of a training program within the Department of Corrections for those EMS personnel. So that's in process with our Office of EMS and Trauma. The second page, this was the core bill that we started out with. It was to address some challenges that we were facing with vaccine administration through our health departments. So now under Georgia law, EMTs and cardiac techs are authorized to administer vaccines during public health emergencies. These aren't necessarily declared public health emergencies. There's a little distinction in code so they can continue administering vaccines even though we're not in a state of public health emergency. And they still must do so under the order of a physician. The second bullet, this allows us to disclose vaccine information to the CDC under certain conditions. Previously, the information contained in GRITS, which is our Georgia Registry on Immunizations, was very limited in who could receive that information and under what circumstances they could receive it. So much so that we weren't even allowed to disclose vaccine information to CDC. And they were using that disclosure in order to determine Georgia's allocations when we first started receiving vaccine in like January, December timeframe. So we actually had to have language included in the governor's executive order to allow us to disclose that information to CDC. So this bill puts it into, it codifies it that we are allowed to continue disclosing this data. It is mostly de-identified. The only identifier that is shared with CDC is a patient's date of birth. And then the biggest part is the third bullet, which revises certain provisions regarding the vaccine protocol agreement. So now under Georgia law, pharmacists can administer any vaccine that is on the adult vaccine schedule. They can also administer the COVID vaccine to individuals 13 and up. Previously, there were only 4 vaccines that pharmacists could administer. I'm going to forget one of them, but it was flu, Shingrix, pneumococcal, tetanus. It wasn't tetanus. I forget the fourth, but it kind of opened up accessibility to especially to individuals in the rural community where they may have trouble getting to a doctor's office or a health department, to be able to go see their pharmacist down the street and get any adult vaccine that they're due for. So that bill did pass at the 11th hour on day 40. Okay, and the next one, this was also an agency bill. This is the House Study Committee on Childhood Lead Exposure. The committee is tasked with studying the effect of lead exposure on children, looking at Georgia's laws and seeing how we can bring the program and our operations more up to date with CDC recommendations and nationwide best practices on this. So far the committee's met twice. They had a meeting yesterday. They'll plan to meet twice more. And generally how these work is at the end of the study committee term, so around December, they'll have a report issued with recommendations. They may be recommendations for legislation, budget items, recommendations for just general operations or tasks for the agencies to do. So we should expect that towards the end of the year, beginning of January, in preparation for next session. I would anticipate likely seeing legislation on this next year.
Joe, I mean, I think that the board will be surprised at what our lead level is, how high it has to be to trigger a response compared to the CDC recommendations, because I'm sure they don't know that.
Right.
And at a time that we have an EPA site, a Superfund site right here in the city of Atlanta, up the road.
Yeah, so right now in Georgia law, they lay out a specific blood lead level in which public health action can take place. Dr. Rustin's the expert on it, but I believe it's I believe it's 15 in Georgia law.
It's 15 with 2 consecutive tests. It's 20 with 1 test. So we're 3 to 4 times higher than the current recommended public health action level by CDC.
Right, because CDC's level is 5. So we're working on that, and we're hopeful the legislature will see the importance of bringing Georgia laws into compliance with best practices from CDC and providing the supplemental resources needed, because we will have more cases that will come into our program at that point. Okay, the next one is, this is just another study committee that we're tracking. The Senate Sickle Cell Anemia Study Committee. They've been tasked with studying the conditions, needs, and problems related to sickle cell and recommend any action or legislation they deem necessary. So this does touch on some of our newborn screening, that is a condition we screen for, and some of the follow-up care we do. So we are just watching that one. Now move into the budget items. We had a lot of exciting things in the amended budget, which is unusual, but I think it just goes to show the attention that was placed on public health early on by the legislature, and the recognized need to provide us some additional support. So we did receive a one-time salary supplement for certain state employees that was provided to all state agencies, not just DPH. We also received funds for a chief medical officer, and as Dr. Toomey mentioned, that's Dr. Millman was brought on board to fill that position. A deputy commissioner of public health, a chief data officer, a senior programmer, and a financial manager to all support us with COVID response. And then we did receive additional funding for the Grady Regional Coordinating Center to coordinate emergency room use. We also, Dr. Toomey mentioned this first bullet in her presentation. We received a significant infusion of funds to improve our IT systems, in particular our vaccine management system and our surveillance program of the future, as Dr. Toomey refers to it as. So those both came to us in the amended budget to the tune of $27.1 million to fund those efforts. We also received an infusion of funds for our ADAP program to support increased utilization of roughly $15.5 million. And then going into our big budget, this is our base budget. We received funds to fund the Krabbe disease pilot screening program. So they're scheduled to begin, last I spoke with the lab, they're supposed to start next week. This is a 3-year pilot to begin testing all newborns in Georgia for Krabbe disease. And then the committee will review the data and make recommendations following the pilot, whether it should be implemented into the full screening panel or not. We also received increased funds for feminine hygiene products at public health facilities. This was a budget item from a couple of years ago that was reduced during budget reduction. So they added some more funds for that. They also put into our base budget the position for the Chief Medical Officer, the Deputy Commissioner of Public Health, and the Chief Data Officer. So those funds will be received by DPH year after year to continue funding those positions. We also received an increase for Georgia Core. This was another reduction that we saw during budget cuts. Same for sickle cell. That was another reduction that was restored. Increased funds for a nurse peer assistance program. That was another budget reduction that was restored for this fiscal year we're in right now. We also received increased funds to support Grady's coordination of the emergency room use, that regional coordinating center. We also received a small amount of funds for our pilot program for PrEP. I believe it's occurring in 3 health departments in rural areas around the state. And then we did receive some funds for improvements and renovations at a few public health buildings. I believe that's through a bond, right? Yeah. So I think you guys all talked about that when you voted on your bond package. The last meeting. And that is it for me. I'm happy to take any questions y'all may have.
Megan, I just have one. This is terrific and a terrific update. My question is about the magic age of 13 for allowing pharmacists. I think it's great that pharmacists can do this. I wonder where you came up with how we came up with the age of 13. And I guess what I'm thinking about is, the enormous number of children that are going to need to be vaccinated once the vaccines are approved in late this year, and how valuable pharmacists would be to be able to help meet that need. I mean, why not 5 or why not something like that instead of 13?
Yeah, I'll tell you the 13 age was in existing law for the flu shot, I believe. So pharmacists could administer flu shots to individuals 13 and older. So the COVID vaccine, it was actually a request of the pediatricians that we mirror that same age range for this purpose. And I think part of the challenge is, I have a toddler who has had a lot of vaccines over the last, 3 years of their life. I think there's some difficulty that, pharmacists may not be necessarily fully equipped to, restrain a child in order to vaccinate them, whereas 13 and older,
Do the milestones.
they're more likely to sit a little still. I think that probably has something to do with it, but this was something that was worked out with the pediatricians over there.
I think of CHOA's struggles to try to meet the testing needs. You can imagine if we have to immunize, several million young kids in a month, how we're going to do that in Georgia.
The other thing I wanted to add that I don't know if John Hopper is on, that Brady is working with us to expand that coordinating center to go beyond the 13 county metro area and actually coordinate the EMS providers to all hospitals statewide, which was really something that was important, and we recognized the need for that as hospitals around the state became overwhelmed with COVID patients. So those aren't those are federal dollars that have come to the state and have been allocated. So it wasn't appropriated during session, but it builds on what we had gotten during the session.
So COVID vaccine can be administered by school nurses, I think, now, right?
Yes.
I mean, for example, if the vaccine becomes available for those over 5, school nurses in Georgia would be able to immunize kids at school, right?
Yeah, any nurse can administer the vaccine under a vaccine protocol agreement or their nurse protocol agreement. They still have to have a supervising physician, but yeah, they're permitted to administer.
Thanks. Are there any other comments or questions from the board? We have a chance to adjourn 1 minute early. So thanks again to Dr. Toomey and the entire Department of Georgia Public Health staff for all the work you've done, and good luck.
Thanks. Thanks, everyone. Thank you so much for your kind attention. Let us know if you have any questions.
You're welcome. Thank you.